Hi, I'm Dr. Jerry Ezon. I'm a family sports medicine doctor, and we're here with virtual medical scribes to help you become a medical scribe. So understand that the medical health record is a very important part of the patient experience. It's very important to document what's been done, and essentially you'll hear this over and over again, that unless it was documented, it wasn't done. So in the old days, we used a lot of paper, and so this talks about how, the old doctors said that we were just going to keep using paper and we'd never go electronic. And medicine has been a little bit slow in embracing this. And part of it is the challenge of introducing electronic medical records with patient care. So we thought that the health records would stay paper, but they've all become electronic. Obviously, we know of the advances in computerization. This is actually the Mac Plus that I actually used on my first hospital and introduced that concept. So electronic health records have a bunch of different names. There's a bunch of different types of them, depending on what facility or hospital you're in. So you might hear things like Epic, which is one of the biggest ones, Athena, McKesson. There's smaller ones like DNA. Cerner is the one we use at our hospital in Temecula Valley, as well as I use Practice Fusion, which is for small independent practices. So why do we have electronic health records? For three reasons. One, you need to improve patient care. So it's always focused on the patient, and this allows the physician and the providers to focus on patient care. Number two, it's billing. If there's no margin, there's no mission. We need to document what's been done so we can adequately bill it. And then the last thing is medical legal. It's important to make sure that we have a full documentation of what's been done in case there are some challenges down the road. So medical malpractice is a big challenge in the United States especially, and physicians are on increasing scrutiny to be able to document what's been done. One of the challenges with physicians is there's just not enough time to get everything done. And it's gotten to the point where it's been estimated that over 2 doctors a day commit suicide in the United States just because they're overwhelmed. And what overwhelms them is the bureaucratic task. But you can see down here, increasing computerization in the practice is a big challenge that's been labeled by the physicians as one of their biggest challenges. And I like this little slide where that what seems to be the problem, Mrs. Johnson? Well, she says, I feel the way you look, because physicians are really burdened by the electronic health records. And the solution to that turns out to be medical scribing, and that's what you're going to be doing. So understand this is the Department of Motor Vehicle, and they just sort of have this sort of concept of, they're understaffed, they're working hard. Those people try to work hard, but they have to spend all their time looking at the computer and not at the patient. And we as humans don't like it if someone's not looking at us when they're talking to us. So, and this is an example of that where the physician is saying, wow, your cholesterol is really bad. He's looking at the screen, not looking at the patient. And then, the patient advocate saying, well, you might want to look at the patient. And when they've looked at studies, physicians who have to do their own computerization medical records only spend about half the time looking at the patient. The rest of the time or more is looking at the screen. So there's something that is very important about respecting a patient. When someone's talking to you, you look them in the eye. They really appreciate that. And we as physicians can get more out of that. So we published this paper a couple of years ago on eye gazing and basically the use of medical scribes to improve patient care, where in this paper we spend over 80% and close to 90% of our time looking at the patient while still getting good charts and having patients be respected because you're focused on them, yet getting our documentation done in a timely manner. So scribing is literally as old as time. There were scribes even in the Bible. Jesus said, but woe to you, scribes and Pharisees, hypocrites, for you lock people out of the gates of heaven. So Jesus didn't like his scribes. I actually like my scribes. And I do like this phrase that doctors save lives, but scribes save doctors. So in the emergency room, it's been used quite a bit, but now in regular office practice, we're starting to use it more. The key thing to understand is that with medicine, there's protected health information, and we use the phrase HIPAA, And it really has to be something that you have to be very, very careful for. So Taylor, let's play a little game. So knock, knock.
Who's there?
HIPAA.
HIPAA who?
I can't tell you. Sorry, it's a bad joke. But anyway, you should not tell secrets to anybody, because if you tell those secrets, you can go to jail. Taylor's one of our medical scribes. And then you can get certified as a medical scribe. There is this one that's approved by the CMS, Centers for Medical Services, that says that you can, through the American College of Medical Scribes, online get actually certified. You have to do these requirements. Basically, you study and pass the test, and then you need 200 hours of medical scribe internship. So if you want to become a medical scribe that is certified, you can go through this program. And then after you get your certification, initially you're an apprentice, and once you get the 200 hours and it's approved, you become a CMSS that you can put after your names on the medical record. And understand that you cannot touch a patient. If you're a medical scribe that's not licensed, you cannot touch a patient. You can go to jail for that. So as a medical scribe, you document, but you don't interact in terms of giving out advice or anything like that. So don't touch the patient if you're a straight medical scribe. Now, in a lot of our places, we actually get the medical assistants and or the RNs to become scribes, and under their license and certification, they can do that. So getting to the actual note, we use the acronym SOAP to let us know what should be in a medical record. And so the S stands for subjective, O is objective, A is assessment, and then P is plan. So you'll see these are the different parts of electronic health records. It starts off with the, in medicine we like our little abbreviation, so CC stands for chief complaint. And then you go through all the various parts of it. At the end there's the diagnosis. FH is family history. HPI you'll hear a lot of is why the patient's there. So it's the history of the present illness. And then that is the subjective, what the patient says. Then there's the impression, which is at the end. And then there's objective, which is physically what we do on the physical exam. PMH is the past medical history. And then there's the problem-oriented medical records and the review system. So these are the various parts of it, and we'll go through them. So the history starts with the chief complaint, and it should be in the patient's own words, and you can put that in quotes as why is the patient here, and you describe them such that they're saying why they're here, and understand that all parts of the medical record should align. If they're here for a right knee, the subjective should talk about their right knee, the objectives should have the right knee in. Ultimately, they could have the medical decision-making talking about the right knee, and then the plan about the right knee. So everything should be in alignment. In terms of the history of the present illness, these are the sort of things that might be asked. What's the severity of the complaint? What's the quality, the location? So for example, is it in the chest or is it on the leg? The duration, how long you've had it, associated symptoms. Modifying factors, what makes it worse, what makes it better, the timing, and then the context of when they have it. So in terms of medication, that's probably the biggest challenge, especially when you have patients with chronic disease. They might be on multiple medications, even up to 20 plus. And so we want to try to prevent adverse effects, and so it's very important for us to go through the medicines and document that we've gone through all the medicines to make sure that what we have in the chart reconciles with what the patient's actually taking. And we can go through different samples of these, but medical history is what's happened in the past, and you might have records from other physicians that you have to incorporate. The family history, usually it's both their immediate family as well as past family, and we're looking at genetic type stuff. Social history in terms of what's their occupation, what's their activities of daily living, and then what is it that they are unable to do now with their social part. The review system is a checklist going literally from head to toe of all the different complaints that could be happening. So we'll ask them, generally, do you have any problems? And these are the things. Do you have weight loss? Those sort of things. And the doctor and provider will specifically go through each thing to make sure that we prompt the patient to try to remember all the things that are going wrong with them. So I think of the review systems like a checklist, and you're going to see this analogy used a lot, that the medicine is going towards the way aviation is. There's very few crashes, there's very few mistakes in aviation because they use checklists. And we use this phrase that those that think they need a checklist or they don't need a checklist are the ones that probably need it the most. So using a review of systems is a good way to make sure we don't miss anything. And then on the physical exam, we'll go through it sequentially depending on what their complaints are, and then the scribe will document those things. And on the physical exam, is typically we'll look at their general appearance, and then we'll go through each system. Integumentary is another name for the skin. You'll have the musculoskeletal, circulatories like your heart, respiratory your breathing, and on and on. So as you go through each one, the provider or physician will discuss with you what they see on each one of those. Then ultimately there's this diagnosis, and part of the diagnosis is the medical decision making. So this is where the provider or physician will go through what their thinking is as to how they came up with the diagnosis. And there are different complexities to the medical decision making. There's minimal, that it's pretty straightforward. You know, you fell, you skinned your knee, okay, that's pretty straightforward. On the other hand, limited could be low complexity, where it gets a little bit, they have a fever, and fever could be caused by a couple different things. And then you can get into moderate and even extensive. So if you have someone with multiple complaints, that could be high complexity. So the MDM, or medical decision making, has those different levels. And this has to do with the type of visit you're at, as well as the kind of billing that you would do for this. And then there's the orders. And so in the old days, you know, doctors would sort of write it all out, and it was actually very challenging to be able to understand it. Now with the electronic health records, on a type situation, you can understand them quite well. And then there's levels of the different charts. And so this is for outpatient, what's called E&M code, evaluation and management codes. And so these are the things you can see on the left, the chief complaint, history of present illness. These are the things that you might need, and depending on how many elements you have, that would come up with a level of billing that the provider or physician can use for that encounter. So emergency medicine, they use a lot of scribes, and this is a resource for that. There's a lot of good books that are out. The Ultimate Scribe series is quite good. We encourage you to consider using that. This is one of my personal favorites, The House of God. It's a little bit of a novel, but I like its idea of sort of the challenges we training physicians have. It's an old book, but it was written right when I was in med school, so I have a lot of fond memories of it. And this is a fun book to look at in terms of the secret language of doctors, of all the different words that we're using. So as a medical scribe, your biggest, one of your big challenges is to get up to speed on the medical terminology. So this might be a nice way to do it. And you might hear these terms of buffing the chart or scrubbing the chart. And basically that's making the note into what it needs. I say that the medical note needs to be like Goldilocks, like not too long, not too short, it needs to be just right. And it really needs to reflect that patient encounter. So in summary, and this is the hospital that I work out of, medical scribing can really help physicians to then help patients. And at the end of the day, that's what our goal is here at Virtual Medical Scribe.